I think acute lymphoblastic leukemia is quite a remarkable example of how management of this disease has changed dramatically over the years. I started many years ago in a pediatric clinic. I was a pediatrician initially up in the north of Italy in Torino. And in those days, children already did better than adults, but the prognosis in those days was roughly around 50%. Now, in a matter of 30-35 years, we're up to curing, again, in the lucky countries, about 85% of cases. So it's not perfect, but it's much better. The advancement has been quite dramatic. In the adults, less evident, but still very important. So we discussed many aspects, and in fact, in my opening talk, I didn't only speak about relapse refractory, but I underlined what have been or are the major changes that we have and are witnessing in management of ALL. That means a precise diagnosis, means that we have to stratify patients largely based on the genetic properties of the leukemic cells, which have to be identified at presentation, because we have targeted treatment for some subgroups of ALL. So I brought a typical example of Philadelphia positive ALL when we have this BCR-Abelson abnormality. And I recall the audience that in the old days this was the worst disease we could have in hematology, and I even said possibly in oncology, because the prognosis was dismal, not poor, dismal. The only option for a patient was to hopefully go to an allogeneic transplant. Now, knowing the abnormality and having developed a tyrosine kinase inhibitor in chronic myeloid leukemia, over time the use of tyrosine kinase inhibitor has been extended to ALL, Philadelphia positive ALL. And this has changed the paradigm of treatment and has changed prognosis. But you have to identify the genetic lesion right at diagnosis. That goes back again to the issue, do you have the facilities? So you have to be in a country or a region or a city or an institute where the molecular biology is available, and you can have the answer in a few days. So in ALL, we have a 1 week pre-phase with steroids, and in that week we have to give the answer, even in samples coming from outside the center or from outside the city where we live. Given that you have the data, then you add the tyrosine kinase inhibitor, and our group in Italy, the GMEMA National Studies and others, have shown that incorporating the tyrosine kinase inhibitors, you change completely the prognosis. Our group has in fact pioneered the use of the tyrosine kinase inhibitors without systemic chemotherapy, and virtually all patients can go into remission. Then I addressed the issue that one of the key points has become monitoring of minimal residual disease. As for many other diseases, but ALL, it's a key point. A patient must become what we say MRD negative by molecular analysis. And what are we doing now to try to improve that? Some groups are adding chemotherapy. We have a protocol now where after a tyrosine kinase inhibitor, we add the monoclonal antibody, which is a bispecific monoclonal antibody blinatumomab, which is a form of immunotherapy. It targets the leukemic cell, but the activation is through the CD3 T lymphocyte of the patient. And the study is ongoing. So we discussed all this and what are the other options. So a lot of discussion was on the other antibody, anti-CD22, inotuzumab, very active for relapse refractory, like blinatumomab. So we have two antibodies that are both active in relapse refractory B lineage ALL. Then we addressed the issue that these antibodies are going to be utilized earlier to try to improve MRD response, as I just mentioned. And then I introduced a theme which is very fashionable today of the CAR-T, immunotherapy with CAR-T. And I discussed this fact, and I said that we'll have a specific talk on this, so I was introducing a whole session. So I thought the way set the scene on the changes in the manner of ALL over the years and where we are going. And the speakers after me discussed in detail, particularly the two antibodies. One speaker, which was David Marks, from the UK, and the other again from the UK, from King's College in London, discussed specifically CAR-T and the application in ALL. And two of us also presented clinical cases in order to show in the real life how you can manage patients with the antibodies. So I think it was well attended, and I think the message was really of the changes. And in other sessions too, I mean, there's been a lot on CAR-T. We've been in many boards and in meetings and to discuss how the development for ALL is increasing over the years.